Okay, thank you very much for what feels like a small group tutorial. I can see about a dozen left in the audience. It's Friday afternoon. I'm extremely sorry for that, so I'm going to be as brief as possible. From a practical point of view, this sounds like, re-engineering the entire healthcare system. The point is we are, but we're doing it piecemeal. So, from my point of view, let's set some context. We're in the UAE. The UAE is not quite at number 18 in the world like the USA for healthcare at the moment, but it's pretty close. It's actually still sending some people overseas, or it was before COVID. In fact, $1.4 billion worth of work. At the same time, there's a lot of health tourism coming into the country. This means that we have patients with records. I've had them in my clinic with 5 MRI scans from 3 different countries. I've had patients come to me for the 11th opinion. Why? Because they're getting conflicting views, and it's very hard for them to elicit the real truth in healthcare. So we need to try and make it easier for the patients. I actually think we're coming into this at a good time. Web 3.0 technology offers us a lot of opportunities, especially when it comes to not only moving towards a community-based system. And the example I'd use for this is that when I was at the Royal National Orthopaedic Hospital, I once over 3 years collected 30 cases of a rare condition, only to find that patients like me were reporting 242 cases. Now, obviously, we need to work on quality as to how we actually analyze that information. But the point is, we need to also be moving towards crowdsourcing information and collaboration. The other aspect is that we can sort out the security side of things now, so we don't have to be doing stuff in one place. Okay, it's the magic clicker. If you haven't heard of smart contracts, please go and read a book about smart contracts. This is going to be the backbone of pretty much everything we do for the rest of the decade. Because of the modular structure of how we build software now, we can have our finance and integrate with project management and have the payment gateways, all these different components. And in the stuff that we develop at Palebly, obviously we can white label it so people can brand it for themselves. Why are we bothering to do this is basically because you can build the validation and verification into any system. That means that we can also, out of the box, ensure that you have ISO 9001, 27001, GDPR compliance, all these regulatory frameworks that normally take startups 2 or 3 years to get their act together and cost them a lot of money. It basically, you can impose those constraints into a system in a way to ensure that people actually are internationally compliant for regulations. Why bother doing this in healthcare? There was a friend of mine, he's in his 30s, and unfortunately his kidneys failed. So he had a kidney transplant, and then his kidney transplant failed. So he finds himself now in Europe basically having to go to dialysis a couple of times a week. That's the rest of his life, he accepts that. But in his 30s, he doesn't want to just spend the rest of his life 10 miles from home. So he wants to be able to go on holiday, and he has to book his dialysis ahead. So, I want to go to Spain. I wonder if they've got dialysis machines spare. The reality of something like that is that you want to be able to manage your medical records, your EHR, take it with you to make sure that you've got this booked up ahead of time. It's not the sort of thing you want to queue for. So we have the ability to give people that degree of autonomy over their own lives and their own care. And that creates this sort of next level community. You also start to get compounding of these different technology curves. One of the beauties of what we're seeing at the moment is it's not just one technology, it's a combination coming together to solve the problems. So to me, I look at this as the perfect storm for healthcare. It's the thing I've been waiting for the last 2 decades. I mean, we were talking about telehealth just now. I remember doing a telehealth conference in 1997, so 25 years ago. There was one very successful application for the system. We're still dealing with things like the war in the Balkans. And in that time, if you could actually tell whether somebody needed to be extricated from a war zone quickly, it would cost you 2 military aircraft and 7 hard vehicles. So it's extremely expensive. So if they only had a cut on their hand and they could come back in the normal vehicles, it would save you a few million. So there's a very clear justification. So you start with these odd cases, and then gradually it rolls out until now, realistically, we're probably talking about half of healthcare is going to end up being telemedicine. In this case, looking at Web 3.0, it's based around these three key areas. We understand crypto, we have the security, we have the technologies to manage this, and that together gives you the ability to manage the identity of the person, the KYC, the AML aspects. And you have blockchains, which, not the right time to go into the detail, can actually be made very effectively. But you want to integrate them with these other services, because ultimately distributed ledgers, blockchain, has been around since about 1972 in the form of linked lists in computer science. So again, this is not a new technology. It's a new application of the technology. Okay, so we see the three coming together. Now, we're talking about rebuilding healthcare. What we're talking about is preparing healthcare for the unexpected. Because up until now, we've had a pretty stable growth in the human population. We've had reasonably good success eliminating certain diseases. The reality is that we're now potentially manufacturing diseases, certainly lifestyle ones, but also probably ones more at the microbiological level. And so it becomes less predictable, certainly more uncertain. And by that I mean harder to mitigate the risks. So what does the body do? The body's been doing this a lot longer than modern healthcare. And therefore, it's already built an immune system that has various features which are key to how it ensures resilience and resourcefulness. So we have redundancy in our system, in our own biology. We have diversity of cell types and mechanisms that we use. We have a modular approach which is integrated. And basically, we adapt. So if you look at our epigenetics, that of an Inuit living in the far north will be slightly different from somebody living in the Kalahari. Why? Because their bodies are a little bit adapted to their environment already. That way we are building in, anticipating the future. So there's an element of prudence. And obviously we embed these systems inside the rest of our biological systems. Why aren't we doing the same with the healthcare model? So, more resilience. I think the first thing to say about this is that basically we have to look at how these components can be not only stable in their own right, but how they can be interacting with each other. So therefore you have the redundancy. And also from the modular side, you don't want one system to take down another. There's a lot of talk about supply chains. Supply chains can become quite brittle, especially when you start talking about live material. So we need to have that redundancy built into the system. Really, it ought to be, dare I say, legislated into the system. We also need to have an adaptive service. So as we move forward, we are getting the machine learning of the big data that's coming in now to see what the trends actually really are. So we can anticipate. Back in a while ago, say 15 years ago, because I'm an orthopedic surgeon, we anticipated a 6-fold global increase in the number of knee replacements over the rest of my career. That's why I don't do knee replacements. Okay, it's just too many. One of the reasons for that is the demographics of the world. Places like India, China, coming online, increasing middle class, much greater demand. People, for some reason, should we say, putting knee replacements in earlier, get good results, write nice papers, and then you have more revisions. And frankly, as an arthroplasty surgeon, revisability is the critical factor. It's like anything else, mode to failure. If somebody's going to fail well, fine, you can carry on. If it's going to fail badly, you're setting yourself up and probably the patient up for another problem. So when we're looking at something like this and we're embedding these components and stuff in our system, we need to think about those mode of failure. Moving on, from my perspective, it's all about how we have the different organizations and how they work together, and very easy access. You want the sort of system that your mother can actually sign up to, probably with a little bit of advice, but they don't have to be technical. The blockchain's happening behind the scenes. AI is happening behind the scenes. It's a bit like, you press the button on your car window. You don't want to know the voltage going through the motor in the door. You just want to know your window's going to go up or down. And it's this element of ensuring security through things like escrow payment mechanisms internationally that give people the sense of ownership, of control of the system. And I think that's really important that we bring patients back into the center, even if they're setting up their own space to book their dialysis, to create an agreement with that hospital with their own smart contract. At least then you're personalizing not only the treatment, but also, if you like, the insurance package and everything else that goes with it. So, why do we have to innovate? Because we have to adapt. We have to adapt because of the grey tsunami. People like me, or people just older than me, I'm X-Gen, the sort of lone wolf generation, but the ones who are older, the baby boomers as they were called, starting to retire now, they're going to be a massive drain on the healthcare system. We're expecting UK to have something like 20% more work with 20% less workforce. You know, it's a trend. It's going to pass through. It'll take 20 years, but it's the reality. We also have this tech elements that we've talked about, IoT, we've talked about wearable devices, ubiquitous computing, whatever you want to call it. But the point is, we can offload a lot of this work. With the AI systems, we can augment the clinical practice. We don't have to eliminate everyone, we just have to adapt. And obviously, patient-centered care. People ultimately, they like the thing which works best. You know, why is iPhone so successful? We need to have a good user experience. And I know I should be standing up here going, you know, clinical is everything. Yes, but clinical you can access is everything. So we need to have that user experience, and the greatest design is the one that wins. So bringing these things together, if we look at curves like this, we see every technology basically goes through the same process, a sigmoid S-shaped curve, whether you're sort of introducing cars or electric cars, whether you're looking at something like 50 years for radios to spread throughout the world or only 10 years for color TVs. The rate of transition depends on the relative value of the technology. So some things can happen extremely quickly. I remember 90% of cassettes were wiped out when CDs came in. Why? Because a CD, nice, clean, simple technology, doesn't break. You know, it's just better. And we're going to see the same thing happen with a lot of these technologies over the next few years. So, to make life simple for people and to reduce the number of slides, we have the enterprise innovation architecture. If you're going to photograph a slide, photograph this one, because this is basically what every company needs to be doing forever. You know, if we think that we're going to get the technology, get it right, and make millions, fine. But the reality is, in 2 years' time, somebody else is probably going to do it better. Unless you have this process of continuous innovation, continuous questioning, and you're looking at time horizons for where you're going to be in 1 year, 5 year, 10 years, you know, sooner or later you will be displaced. So I see this foundation is partly how we're going to change the structure. We're going to have to change the beliefs to some extent, especially looking at a longer horizon. Everyone wants a bite of the donut, but the question is, how disruptive is that going to be? We want to make sure that, this is the old slides, I'm afraid, that we acknowledge the trends which really matter. You know, exponential increase in blockchain and, you know, 1.4 trillion already market cap. Gartner curve, everybody should know. This is the one that matters to me, is the types of data now that we're using around the web with linked open data. We need to be moving, this is a W3C standard. This means that we can actually share data, especially government elicited data, shall we say, paid for by the taxpayers. There's about 40,000 databases worldwide. That is going to mean that we actually can get up to date. We're going to have to adapt with the lighting. I'm sorry it doesn't show very well, but this is a 3D reconstruction of MRI scan, which is not something we normally do. We don't yet have the formatting for that. When I build that into a VR simulation, there's no formal standards. So we're going to have to adapt. We're going to have to build the procedures into the company. And in healthcare, we're going to have to accept that with the medical records, there's multiple agents who want to have access to these platforms, especially the hospitals, which are still getting the money. So we're looking at hybrid. We're looking at financing with other crowdsourced and collaborative as well as centralized mechanisms. And if we come down to the enablers, you can simply put it down to the smart contracts and the use of AI for filtering, for the prediction and for the security, so that when we actually engage, we can engage at all levels, whether it's the user, the group, the association, or the venture, and that we can actually meet the cost of this, looking at self-sovereign identity. I don't think we need to go into the detail of that. So the bottom line for me, the life science scale, we have to accept these things interact with each other. Anyone who's done biology in the last 20 years probably is used to this sort of scale. But the point is that what's happening with the genomics and epigenomics is going to have effects at the cellular level, the subcell, cell systems, tissues, organs, through the individuals, and then up through the life science scale. So, the important numbers, 1, 2, 7, 15, 150 with the Dunbar number, 500, and then a log scale. The point is that all these things have a knock-on effect. Okay, so I'll keep it to that. Thank you. Any questions? Time for tea?